Hello, my name is Crystal Wright, and I am an adult geriatric nurse practitioner. And I'm going to talk to you today about stroke care for the advanced practice RN. And I'm going to try to connect stroke care to the geriatric population because there are some special considerations to think about when you're caring for a stroke patient who is geriatric. And so we'll talk about that today. So my background is in neurology, and I have worked in neurology for almost 2 decades, both as a nurse and as a nurse practitioner. And I currently work at UT Southwestern Neurology Clinic in Dallas. So let's get started. So the learning outcomes, at the end of this activity, the advanced practice registered nurse will self-report understanding of stroke care in the older adult and the implications to nursing and patient outcomes by completion of the post-activity evaluation and scoring at least 80% or greater on the post-test. The objectives of today's talk is going to be to recognize the impact of cerebral vascular disease on the older adult, recognizing the early signs of a stroke, being able to distinguish between an ischemic cerebral vascular event and a hemorrhagic event, understanding the initial management for both ischemic and hemorrhagic cerebral vascular events, and understanding the long-term prevention for both. So stroke is the leading cause of death and disability among older adults. And in the United States, there are about 750,000 strokes per year and about 150,000 deaths per year as a consequence of stroke. And in the US, it's estimated that the healthcare system spends about $65 billion a year on stroke management. So when we discuss stroke, there are many risk factors that are involved, and we're going to go over some modifiable risk factors as well as non-modifiable risk factors. And in this first slide here, it's the non-modifiable risk factors. So age is number one, and as you see, the risk doubles with each decade of life after the age of 55. Males are more likely to have strokes as well. And then race and ethnicity also play a role. The highest rates are among African Americans, East Asians, and Hispanics. And then family history plays a role. Those who have a family history of stroke are more likely to have a stroke themselves. These are the modifiable risk factors. And some of these are fairly obvious, and some may not be. So the prior stroke or TIA increases the risk of having an ischemic event. And then having uncontrolled blood pressure or high cholesterol, diabetes, having atrial fibrillation, and then elevated homocysteine is also on this list. Homocysteine is an amino acid that our body produces, and having high levels is thought to be toxic to the vessels. And so it increases the likelihood of having stenosis and stiffening of the vessels. And then carotid stenosis, smoking, alcohol abuse, obesity, and physical inactivity. These are some mimicking conditions that we want to rule out when someone presents with stroke-like symptoms. And that's going to be a seizure, mass lesion, so something like a tumor or a subdural hematoma, systemic infection, migraine, toxic metabolic encephalopathy, encephalitis, or multiple sclerosis, or hypoglycemia. Stroke subtypes. So as we discuss in the objectives, there are two main types of stroke, so there's ischemic stroke and hemorrhagic stroke. And an ischemic stroke is a stroke that's caused by an occlusion of a cerebral blood vessel. It accounts for about 80 to 85% of all strokes. And the origin can be from a cardiac emboli, or it can be a large vessel occlusion, a small vessel occlusion, or a cryptogenic stroke. And a cryptogenic stroke is a stroke that does not have a clear cause. So with hemorrhagic stroke, it's actually caused by a sudden rupture of blood vessels that lead to bleeding inside of the brain. And the two main types of a hemorrhagic stroke is an intracerebral hemorrhage and a subarachnoid hemorrhage. Now today we'll also talk about a couple other types of brain hemorrhages that are not considered stroke, but are caused by trauma. And I wanted to include them because their management is similar, and we do see those in the older population. So we'll start with talking about the ischemic strokes. So the cardiac emboli stroke. This is potentially preventable, and it is usually caused by atrial fibrillation, and that's for about 25 to 30% of all ischemic strokes are due to atrial fibrillation. There's a 4 to 5-fold increased risk, and the reason why there is such a high risk in individuals who have AFib is because clots form in the left atrium, and then that blood is pumped out and can go straight into the brain and block blood flow. And so with a cardiac emboli stroke, typically you have a lot of neurological deficit at the onset of the stroke. And you can see in this picture here, the ischemic area is quite large because typically these clots are quite large, and they block blood flow from getting to a large portion of the brain all at once because it clogs a large vessel. And in a cardiac emboli stroke, there can be a couple of other causes besides just atrial fib. And we do see them in mechanical heart valve with individuals that have mechanical heart valves, those who have had a recent myocardial infarction, or individuals that have blood clots form in other areas like the left ventricle, and then dilated cardiomyopathy can occur, a kinetic left ventricular segment, left atrial thrombus, an atrial myxoma, or infective endocarditis can all be causes of cardiac emboli strokes. What are the features of a cardiac emboli stroke? Well, it depends on where the clot gets lodged. You could have cortical features or cerebellar features or brainstem, or even subcortical. And usually the clot is greater than 1.5 centimeters. And because of this being a large clot, and once the clot is lodged, it takes away blood flow to a large portion of the brain, the maximal deficit is immediate. It is as soon as the clot occurs. And this is not usually preceded by a TIA. It's usually a kind of a standalone event, not meaning that it can't reoccur, but it just doesn't usually occur from a TIA because it's a different type of clot. So next we'll talk about the large vessel disease. And usually this is from arteriosclerosis, and that accounts for about 20% of all ischemic strokes. And it's actually due to progressive occlusion of cerebral vessels. This usually occurs with stenosis, and usually it's where there is greater than 50% stenosis of the proximal artery. And there is usually no cardioembolic source when this occurs. And as you can see in this picture, again, there's a large area of ischemia. The clot can be seen there, and then as you know, you can see that there's everything from the blood flow from that area on is basically damaged with a large vessel stroke. Now, a small vessel stroke, these may be the strokes that go unnoticed. So the small vessel strokes are occlusions of the small little penetrating vessels that branch off those larger vessels. And so they may not be supplying as much tissue with blood supply. And so if that gets blocked off, you may see these on imaging, but you may not have a lot of symptoms from them. And that's usually they're caused from the microatherosclerosis or the lipohyaline, which is, hardening and thinning of the little bitty tiny blood vessels. And it's often associated with individuals that have chronic hypertension or diabetes or both of those. So let's compare the two, the small vessel versus large vessel disease. So large vessel features, again, are because it's a larger clot, you're going to have more widespread symptoms, and it can be cortical or cerebellar or brainstem, and there's going to be usually cortical or cerebellar signs and symptoms when these people present. Oftentimes they'll have had a history of a TIA in the past, and these can often be identified with non-invasive imaging of the carotid arteries. You'll see that there's usually some stenosis in the carotid arteries, or the MRA may show some stenosis there. So a small vessel feature is going to be a smaller clot to begin with, and that can be subcortical or brainstem. And these are not going to really pick up on a CT. Usually it's going to be something that you're going to need an MRI in order to really see these smaller little strokes. And they're called lacunar infarcts is the term for these small vessel strokes. And again, they're not going to be seen on the Dopplers or CTs or even MRAs. You probably will have normal Doppler, CT, and MRA in small vessel disease. But if you do an MRI, that's where you would see these little tiny areas of damage. So there's no large artery or cardioembolic source with the small vessel disease. And usually, again, these are people with history of diabetes or hypertension. So they have a high risk factor for having arteriosclerosis and damage to the arteries and vessels. So usually there's no cortical signs or symptoms. And like I said, an MRI or CT may be normal, especially in the initial phase. The MRI may not show the damage just yet. So when we talk about cortical symptoms, with large vessel, you want to think like neglect or aphasia, those types of symptoms, where with small vessel disease, you may have like purely motor symptoms or hemiparesis, like affecting the face or an arm or leg, those types of things. So a cryptogenic stroke is basically a stroke that a cause cannot be found. And this accounts for about 23 to 40% of acute ischemic strokes. And anytime you cannot find a reason for a stroke, you really should consider atypical causes of the stroke. Things like vasculitis can look like stroke on MRI. Usually with vasculitis, it's fairly widespread, more the appearance of what you'd see in small vessel disease, but it could look more like large vessel, just kind of depending on the person. But you got to think also about coagulopathies and mitochondrial disorder. And again, mitochondrial disorder tends to be a little bit widespread on MRI. Widespread damage that you would see to the white matter. And then prolonged cardiac monitoring should always be considered in these cases, because it may help determine if a person may have intermittent atrial fibrillation. So there's been some research with using devices like the Watchman, kind of the implantable devices, to look for cases of atrial fib in individuals who've had cryptogenic strokes. So a TIA, or a transient ischemic attack, is exactly what it sounds like. It is an attack that occurs due to an ischemic event, but it doesn't stick around. And so basically it's a brief episode of neurological dysfunction caused by focal brain or retinal ischemia. And clinical symptoms usually last only a few minutes. However, they go away. So it's not like the regular ischemic stroke where someone would have an event and they need to go to the ER, and those symptoms may not resolve for months or years, or may never go away. But with a TIA, the symptoms will typically go away in about an hour, but in some cases they may last longer, up to 24 hours. And in order for it to be called a TIA, there has to be no evidence of an acute infarction, meaning that the diagnostic tests are negative for a stroke. So when someone has a TIA, it's very important that that person is given a full workup to make sure that there is not a cardiac cause or a clotting reason, there's not a recognizable reason why they are having this event. Also, individuals with TIA, they need to be worked up for those mimicking conditions that we talked about. You should be able to kind of streamline a little bit and say, okay, well, this one, obviously wasn't a seizure or things like that, but you may consider working them up for other things on the mimicking list after having a TIA. So even with episodes lasting just an hour, there is a risk for permanent tissue injury. So with a TIA, about 1 in 3 people will eventually have a stroke, and about half of those will occur within a year after the TIA. And so this should serve as a warning. And as soon as you have a patient that presents with symptoms similar to a TIA, or you think it might be a TIA, this is the time to evaluate all of their risk factors and work with the individual on those modifiable risk factors. The things like obesity, helping them get to a healthy weight, or start an exercise program, or improve their cholesterol or blood pressure, or things like that. Now, we always want those things to be improved before they have a TIA, but when a TIA occurs, that is when you definitely want to go back and say, okay, what type of things are not optimal right now that can be modified to help prevent this from occurring again. And we'll get into the management of those, of the ischemic and hemorrhagic stroke, as well as the TIA, a little bit later in this presentation. But right now, we're going to go ahead and move into the hemorrhagic strokes and talk about that, as well as some other hemorrhagic brain injuries. So hemorrhagic stroke is a ruptured blood vessel, and that basically causes bleeding inside or around the brain. It accounts for 15 to 20% of all strokes. There are 4 subtypes based on location, And so we're going to talk about the intracerebral hemorrhage and subarachnoid hemorrhage. Those are the two types of true hemorrhagic strokes. But we're also going to talk about the subdural hematoma and epidural hematomas because those are also hemorrhages. They're just not necessarily classified as a true stroke. So intracranial hemorrhage, it's an abrupt onset of focal progressive neurological symptoms, and it's basically caused by bleeding in the brain that is a result of usually hypertension that causes a rupture of a microaneurysm. And other causes are listed here. It can be from arteriovenous malformations, coagulopathy, amyloid angiopathy, drugs, vasculitis, idiopathic thrombocytopenic purpura, cavernous angiomas, dural venous sinus thrombosis, brain neoplasms, cocaine, alcohol use, intracranial aneurysms, and hemorrhagic ischemic strokes and trauma. So in the elderly population, it's usually from hemorrhagic ischemic strokes or from trauma. And it's usually due from hypertension. So on the CT scan that you can see over here, you can see the hyperintensity, the white area in the middle of the brain there, that's the bleed. And you can see how it's really just kind of infiltrated the ventricle there. You can't even see the ventricle on the left side of the brain. So an intracranial hemorrhage can be associated with severe headache, vomiting, very high blood pressure, loss of consciousness, and even seizures. And it's diagnosed with a CT or an MRI, typically a CT though, and these are going to be non-contrast CTs. And on the CT, you will see the bleeding itself, and that's what you can see, like I said, on the image here. You can see the blood as a hyperintensity there on the CT. So on subarachnoid hemorrhage, this is most often caused from a trauma. It can also be caused by a rupture of an aneurysm, normally the circle of Willis. And a spontaneous subarachnoid hemorrhage can also occur. We don't really see spontaneous ones very often in the older population, but it can occur, and that can be associated with sickle cell anemia, certain drugs of abuse, and coagulopathy. So as you can see on this CT scan, blood is taken over the subarachnoid space. So it's the area there kind of in the center of the CT. And so as the blood has leaked out, it's actually pushing and irritating the meningeal meninges there. And so individuals that have a subarachnoid hemorrhage often present with symptoms of meningitis. They don't necessarily have the fever that you would see with meningitis, but they have the neck pain, altered consciousness, headache, seizures. So the symptoms, the most common ones are listed in the headache, the seizures, thunderclap headache is the kind of the tall tale sign that it might be a subarachnoid hemorrhage, and to consider that. So the next type of hemorrhage we'll talk about is a subdural hematoma. And a subdural hematoma is a collection of blood between the dura and the arachnoid as a result of lacerations and tears in the bridging vessels on the surface of the brain. And this is usually due to trauma. You'll see this in the older population from falls. And the older population is more susceptible to this to start with. And then sometimes you'll see it as really with no falls, there won't be a history of a fall. It may just be kind of a chronic subdural hematoma, and we'll talk about that here in a minute. One characteristic you'll see on CT is, depending on the size of the subdural hematoma, you may have a mass effect and a midline shift. And what that means is, you can see on the CT here, so on the picture, it's going to be on the upper right-hand corner. That's actually going to be the left side of the brain. And you can see the fluid that's accumulated there. That's the white area where the arrow is pointing. And so as that fluid is pushing on the brain, if you look over at the ventricles, which are the black areas there that should be midline, they are no longer midline. They are pushed to the right. And they are actually, both ventricles look to be on the right side of the brain in the CT image. And so what's happening is the blood volume is pushing the brain and squishing it to the right side. And you can tell that you can see that the left ventricle is squished quite a bit in this particular patient from the mass effect that's occurring. So chronic subdural hematoma, this is more likely to occur in the older population. Incidence increases with age, and symptoms can include headaches, cognitive impairment, focal neurological symptoms, and even possibly seizures. This can occur without a history of head injury, and that is the case in about 50% of cases. Risk factors for chronic subdural hematoma are going to be clotting disorders, individuals that have had shunting procedures done, or those who have had seizures. They're more likely to, number one, have injury from the seizure with head injury. But also, seizures may come from that chronic subdural hematoma. So kind of both ways with that. So if the patient is symptomatic or there's been worsening and the hematoma is greater than 1 centimeter at the thickest point, you can consider surgical intervention. However, if it looks like the patient is improving, their focal symptoms seem to be getting better, or they have no symptoms at all, which is sometimes a possibility. I've seen patients with large hematomas and they really don't have a lot of symptoms. I've had patients after falls that they feel pretty good, and we get a scan for another reason and they have a hematoma and they feel okay. So in those situations, if someone's asymptomatic or they're improving, then maybe just watch them and make sure that they're not having complications. But definitely, don't send someone who's asymptomatic for surgery. So the next one we'll talk about is the epidural hematoma. And this is an extraaxial blood collection that occurs between the skull and the dura. And as you can see on the CT, they appear as a bioconvex or a lenticular shaped hyperdensity. So it's the white area that the red arrow is pointing at, and you can see the bioconvex shape right there. And so the 85% of these are associated with skull fractures and tears of the meningeal arteries. And these individuals present a little bit different than with these other hemorrhagic events. So these people typically have a loss of consciousness from the trauma. So maybe a fall or an accident, maybe a motor vehicle accident or something like that. And they may have lost consciousness initially, but they regain consciousness and have this lucid interval for several hours, and then they start to have a rapid deterioration. And so you can, anytime you have someone who meets that picture, you definitely want to get them to a hospital as soon as possible. And if the hematoma is greater than 1 centimeter, then usually it will require immediate surgery. And you can tell with this individual here, there is a mass effect occurring as well. The brain is being shifted from the pressure of the blood being up against that dura. So initial management of suspected stroke. What do you do when you suspect someone has a stroke? And this includes what you would do hospital setting as well as outpatient. I'll try to decipher the two as we move forward. So initial assessment of anyone who you think may be having a stroke or have had a stroke, definitely history and exam is very, very important. You want to assess severity and pattern of neurological deficits using the NIH stroke scale. And we'll talk about that in greater detail in a few minutes. And I'll give you a link that you can go and look at the questions and read through them as well. You want to identify history of or risk factors for non-stroke causes. Again, we talked about some of those mimicking conditions, migraines, seizures, drug intoxication. We want to make sure that there's not another explanation. And MS is one of those things too that may present acute relapse in multiple sclerosis may present like a stroke. And so we want to know if the patient has a history of multiple sclerosis, because with that individual, you may need to look on the MRI and see if it is a demyelinating event versus an ischemic event before considering aspirin and things like that. So CT brain should be done as quickly as possible. The CT of the brain is kind of the gold standard first thing you need to do. You need to rule out a hemorrhagic stroke first. And the CT is always done without contrast. I remember from nursing school years ago that, you don't give contrast if you expect a hemorrhage because that contrast has to go somewhere and it's going to get into the blood-brain barrier, and it's just going to mix with all of the blood and not a pretty thing. So we don't want that. So we want to do a CT without contrast. And then you want to manage individuals for, dehydration, things like that. You want to make sure that they're hydrated well. Give IV fluids unless contraindicated for another reason. You want to supplement oxygen, make sure that oxygen looks good. If they are having any fevers, you'll treat that with antipyretics. And then initial labs should be CBC, PT, INR, PTT, BMP, cardiac markers, if you suspect that there may be a cardiac cause. Now, this right here is going to be in a hospital setting. If you have someone in a office setting that comes in with stroke-like symptoms, you will get an initial history and exam, but you're probably going to be sending that patient on to the hospital to get a CT of the brain. And so you're not going to be giving them IV hydration and oxygen and all that stuff. You're going to be getting them in an ambulance as soon as possible. So once a diagnosis is made, you definitely want to consider giving TPA and also starting a long-term antiplatelet treatment if indicated. Now, this is for ischemic strokes. You're not going to consider TPA or antiplatelet therapy in a hemorrhagic stroke, but for ischemic strokes, you would. Control the blood pressure while avoiding hypotension. And also a good control of blood sugars is also very important. So if your glucose is less than 60, it needs to be treated. And if it's greater than 180, it needs to be treated. So tight control in those diabetics during this period, especially within the first few hours after a stroke, are very important to get tight control of that. And then preventing DVT, so you may consider giving this patient a low molecular weight heparin or something like that if we're not going to be doing TPA, and SCDs may be warranted, those types of things. Now, until a swallowing study can be done, you should avoid oral intake for risk of aspiration. Oftentimes with a stroke, these patients have dysphagia, and you don't want to have aspiration. So hold any oral intake until a swallowing evaluation is completed. You want to detect and treat any coronary ischemia, heart failure, or arrhythmias. So these individuals really do need to get EKGs to see if there is something like that going on. And if TPA fails to dissolve the clot, you want to consider endovascular thrombectomy. We're going to talk here in a minute about TPA and thrombectomies a little bit more. So we talked about managing the blood pressure in those initial phase right after a stroke. And so I want to talk about that a little bit more because it's very, very important that the blood pressure is managed correctly after a stroke. So when managing blood pressure during or immediately after a stroke, remember that during brain ischemia, the cerebral audio regulation is impaired. And so cerebral blood flow becomes dependent on the actual blood pressure at that time. And so you have to have enough blood pressure to give oxygen to the brain. And so there's different parameters for those who will be receiving the TPA and those who do not receive TPA. So we'll talk first about those who will receive TPA, because you want to get that blood pressure managed pretty quickly in those individuals so they can get their TPA. So once you see the patient, determine if they can have TPA, and you decide yes, they're going to get TPA, then you want to make sure their blood pressure gets under control before giving the TPA. So the systolic blood pressure needs to be less than or equal to 185 millimeters of mercury. And then the diastolic blood pressure, it needs to be less than or equal to 110 millimeters of mercury prior to treatment with the TPA. And then once you give the TPA, the first 24 hours after the TPA, you want to keep the systolic blood pressure less than 180 and diastolic less than 105. We are giving these people an anti-clotting agent. We do not want them to have a hemorrhagic stroke after we've given them blood thinners. So the blood pressure has to be in check. Okay, so what about managing blood pressure for those who will not be receiving TPA? And so with these individuals, you do want to make sure that the brain is getting plenty of blood supply and oxygen. And so you do not treat high blood pressure unless one of the following are true. And that's going to be a systolic blood pressure that is higher than 220 millimeters of mercury, or a diastolic blood pressure that is higher than 120 millimeters of mercury. Now, outside of those there's a couple of other situations where you would go ahead and treat the blood pressure. And those are listed here as well. So if the patient has cardiac ischemia, then you may go ahead and treat the blood pressure to bring it down a little bit. Or if they also have heart failure, or they've been diagnosed with an aortic dissection at the current time of presentation. So those are different considerations to think about. And then if an intracranial hemorrhage is identified, of course, you would want the blood pressure to come down. And there are guidelines for that later on as well. But in the event that the patient is not going to get TPA, we allow the blood pressure to be a little bit higher. So diagnostic testing for individuals who present with stroke-like symptoms. Again, non-contrast CT of the brain is really the gold standard, and that rules out a hemorrhage before TPA is given. And so if you have a normal CT of the brain, that does not mean that you don't have an ischemic stroke, but it means you do not have a hemorrhagic stroke. And that has to be ruled out, because if you give someone TPA who has a hemorrhagic stroke, you are going to have a problem. So again, CT of the brain first. And then an MRI of the brain may be done after that. MRIs do not detect early hemorrhages. That's why the CT has to be done first. But MRIs are much more sensitive for ischemic events and detecting mimickers like MS or tumors. And then carotid Doppler may be done, or even a transcranial Doppler. An EKG may be done at presentation to look for arrhythmias or for myocardial infarctions. Echocardiogram can also be done. Now, an echocardiogram by itself has really shown, not really shown much benefit unless the EKG or the history really suggests that there may be a cardiac cause. So take that into consideration. However, a transesophageal echocardiogram can view more than the transthoracic echocardiogram. And so sometimes it can kind of provide better quality imaging than the regular echocardiogram, and may be considered if, later on, if even the EKG doesn't really show anything. Additional blood tests to rule out clotting disorders such as SED-rate, fasting homocysteine, antiphospholipid antibody to check for clotting issues, protein C for clotting, and protein S for clotting. So the NIH stroke scale is what we use to determine the severity of a stroke. A higher score shows a greater impairment and is prognostic of less favorable outcomes. And scores are obtained based on level of consciousness, best gaze, visual fields, facial palsy, motor strength, and then limb ataxia, sensor exam, language, dysarthria, and extension and inattention. So on the NIH stroke scale, I've given you the website there that you can go and print off your own stroke scale if you would like. Said you're looking at all of these areas, and there are questions that are based on these areas. For example, level of consciousness. If the person is alert, they would get 0. But if they only respond with reflex, motor, or autonomic effects, they would get 3 in that area. And so the higher the score, the worse the prognosis is. So a score less than 5 usually means that they're going to have a better prognosis and do well. But a score greater than 20 really suggests a poor prognosis and possibility of long-term complications. So interventions for strokes. So TPA, we've talked about that a little bit. Let's get into a little bit more detail about what that is. Intravenous tissue plasminogen activator, or TPA. It is known as the brand name Alteplase, and it has had a huge impact on improving ischemic stroke outcomes. And it is FDA approved for the first treatment for acute ischemic strokes. Now, TPA is basically an antiplatelet therapy that causes it dissolves the blood clots that may be blocking the flow to the brain, and it helps restore the blood flow to the regions that may be affected by the stroke. And it has been known to improve long-term functional outcomes and mortality. The earlier it is given, the better. And the window for that is now about less than 4.5 hours. So the inclusion criteria is it has to be an ischemic stroke. By that, it means that you have done a CT and the CT is negative for hemorrhage. There are going to be times where you may give TPA and you have not seen the stroke on MRI because it may not be visible yet, or you may not be able to see it, but you have done a CT, it's negative, you think it's a stroke, the patient looks like has symptoms like it's a stroke, it looks like a stroke type thing, then you may go ahead and give the TPA if there's no, if the patient meets the inclusion criteria, but doesn't have any, doesn't meet any of the exclusion criteria. We'll talk about that in just a second. You want to talk about risk with the patient if they're alert and oriented, if they're unable to understand the risk at that time. You may want to talk with the family and make sure that everyone is on board with them getting the TPA. So this is the exclusion criteria, and you can tell, let me go back one, see how short the inclusion criteria is versus the exclusion criteria. So when to not give TPA. So if any time someone has minor symptoms or symptoms that seem to be clearing on their own, then let's not give them TPA. If there is CT evidence of a multilobar infarction, then you don't give TPA. If the baseline INR is greater than 1.7, or they have a platelet count that is less than 100,000, or they've received heparin in the previous 48 hours, then you cannot give TPA. And that's going to be a risk of bleeding, of course. And then pre-treatment systolic blood pressure greater than 185 or diastolic greater than 110. And we talked about that. If you know they're going to be getting TPA, get that blood pressure down as quickly as possible so they can get the TPA, because it has to be down before they get it. Prior stroke or head trauma in the last 3 months, or evidence of active bleeding or trauma like a fracture to the skull. If they've had major surgery within the last 14 days, or if they've had an arterial puncture at a site that cannot be compressed, then in the last 7 days, then they cannot have it. So 14 days for surgery or 7 days for an arterial puncture. And then prior intracranial hemorrhage before, if they've had that before, then nope. A GI or GU hemorrhage within the last 21 days. And then if they've have seizures, you do not give TPA. Myocardial infarction within the previous 3 months, and blood glucose less than 50. And again, we talked about getting the blood glucose managed quickly, just like the blood pressure. So if TPA is not enough, or TPA is contraindicated, there is also an endovascular thrombectomy. And what that is the clot retrieval device. This device is inserted into the vessel through a catheter, and once it is at the site of the clot, the tip is expanded. So it's very, very tiny and skinny when it is inserted. And then there is a catheter that it goes through, and the surgeon opens it up. It allows the actual device to grab a hold of the clot, and then they can pull it back out through the catheter. So this was initially approved in 2012 to remove blood clot and restore blood flow in stroke patients who could not receive TPA, or for those patients who did not respond to TPA. Well, in 2016, they changed it to say that the device could be used in patients in addition to the treatment with TPA if they used it within the first 6 hours of the onset of symptoms, And then in 2018, they came back and said, well, you can use it together with TPA if you do it within the first 24 hours after symptom onset. And so this has really been helpful at getting the clot when TPA alone is not effective, or in individuals who cannot have TPA. So carotid endarterectomy is basically a procedure where a carotid artery is cut and they remove the plaque and stitch it right back up. And so this is something that can be done if there is stenosis of 50 to 99% in a patient who has symptoms of a blockage. And it can also be considered in individuals who don't have symptoms, but in that case, they need to have a 60 to 99% blockage on one side. And so this is a procedure that has had a lot of media and controversy over. And so there is now what's called a Choose Wisely initiative. And basically it is, if you need to do this, then you really need to choose someone who knows what they're doing. So choose a surgeon who has lots of experience. And if the person is asymptomatic, try to consider modifiable risk factors over surgery. And the reason why this whole initiative has started is because of the safety of this procedure. There are quite a few complications with it. And so you can see here that 2.3% of patients who have the procedure have a stroke. And then there is a rate, almost 0.4 to 7.7% of patients have what's called a cerebral hyperperfusion syndrome. And what that is when individuals have reduced blood flow to the brain for a prolonged period of time, their brain adjusts to that. And when the blood flow is opened up, all of a sudden there is increased blood flow to the brain and there is hyperperfusion that occurs. And if that happens, it actually causes damage to the brain tissue. And there's a high mortality rate if this occurs. And this is more likely to occur in older individuals over the age of 75. And if someone has had an endarterectomy, you should suspect that this is occurring if they're having a change of level of consciousness, they're having headaches and or seizures within 2 weeks of the actual procedure. Okay, so TIA management. So we talked a little bit about TIAs and kind of how to work them up a little bit. But we'll talk a little bit more about risk factors in preventing another stroke, or preventing a stroke from occurring in the first place is how I should word that. So TIA management, early workup. We're going to consider hospitalizations if outpatient testing cannot be done within 48 hours. So these are the individuals that you're more likely to see in an outpatient setting. They come to you with symptoms that may have occurred earlier. Maybe it was yesterday or even earlier today, or maybe it was 2 weeks ago. Sometimes it's, I've seen that happen. So if this was, if the event occurred earlier in the day or yesterday, and you do not think you can get this person worked up in a timely manner, then you need to go ahead and consider a hospitalization. And then if not admitted, so if you're going to be doing their workup outside of the hospital setting, you do need to give them ER warnings, and so they know if they need to go to the hospital and when they need to go to the hospital. So the whole goal of management after a TIA is to prevent a reoccurrence of the TIA and to prevent a stroke. So you're going to treat the cause if you can find the cause and manage high-risk conditions and prevention measures for the ischemic stroke. So this is the risk of a stroke following a TIA. And in a 2016 report, it looked at individuals after a TIA or minor stroke and followed them to see what the actual risk was of them having a stroke following that event. What they found was that 1.5% of individuals did go on to develop a stroke within 48 hours. And then 2.8% went on to develop a stroke within 30 days. And then 3.7% went on to develop a stroke within 90 days. And then 5.1% within the next calendar year. And at the 5-year mark, 9.5% of them had had a stroke. So as you can see, it's pretty significant that those who have a TIA could go on to have a stroke. And so risk factors definitely need to be managed. Okay, TIA management. So we use something called the ABCD score to determine if the individual should be hospitalized after a TIA. And so, and what their risk might be for having a TIA within the next 2 days, and that's why hospitalization would be recommended. So this ABCD score is actually based on their age, blood pressure at onset, and then clinical features, duration of the symptoms, and then if they have diabetes. So an age greater than 60 gives them a point. Blood pressure elevation at diagnosis, so a systolic greater than or equal to 140 or a diastolic greater than or equal to 90 gives them a point. If they had unilateral weakness, they get 2 points added. If they just have isolated speech disturbances, it's 1 point. If they have symptoms that are just sensory or just motor and not unilateral weakness, it gives them 0 points. And then the duration of the TIA symptoms, if it's greater than or equal to 60 minutes, they get 2 points. If it's 10 to 59 minutes, they get 1 point. If it's less than 10 minutes, 0 points. And then if they are diabetic, they get a point. So that score is used, and if a score is greater than or equal to 3, then it is recommended that an individual be hospitalized after their TIA. Now, if their score is 0 to 2, but there is an uncertainty of the diagnostic workup, the fact that it could be done outpatient and they need to go ahead and be admitted, or if they cannot get a workup within the 48 hours, then they need to be admitted. And then if there is a score of 0 to 2, but there is evidence that the event was caused by a focal ischemia, they need to go ahead and be admitted. So those are the 3 instances where the patient should be admitted. So a score greater than or equal to 3, or a 0 to 2 with the evidence of focal ischemia, or unable to do workup outpatient within 48 hours. Okay, so we've had a lot of talk about ischemic strokes and treating them with TPA, but now we're going to talk a little bit more about long-term prevention and management once we do the initial TPA. So we're going to talk about navigating through antiplatelet and anticoagulation therapy as a long-term preventative for ischemic strokes. TIA and antiplatelet therapy. So immediately following a TIA, we would want to consider antiplatelet therapy. If someone has a low ABCD score of less than 4, you would want to start them on an aspirin. Notice that the dose is recommended to be 162 to 325 milligrams daily. So that means that they're either taking 2 baby aspirin or 1 full dose aspirin a day. And then for high-risk patients whose ABCD score is greater than 4, a dual therapy is recommended. And that dual therapy is going to be aspirin and clopidogrel. And the initial loading dose of clopidogrel should be between 300 and 600 milligrams, but then 75 milligrams daily thereafter. And the combination of the 2 of these drugs should continue for the first 21 days. Now, if someone has a TIA and they are already on an aspirin at the dose above, so the 162 to 325, and they have a TIA again, then we should really consider going to the dual therapy because the standalone therapy has not worked for them. And so you would probably go ahead and do dual therapy. Now, with an older individual, you want to be cautious with this because of the slight increased risk of bleeding. So make sure that fall risk is assessed and that the individual is less likely to have an issue with it. Stroke and antiplatelet therapy. Immediate treatment following an ischemic stroke. The recommendations are very similar to what you would see in the TIA criteria, except you are going to use the NIH score. So for low risk, so an NIH score less than 5, you're going to start aspirin. Again, it's going to be 162 to 325 milligrams daily. Then for high risk, the NIH score would be greater than or equal to 5, and you're going to do a dual therapy of aspirin and clopidogrel. And just like in the TIA management, the dose is the same. Consider continuing it for 21 days, the dual therapy. Now, if the person has an intracranial large artery atherosclerosis that led to their stroke, you would continue it for 90 days, the dual therapy. And then if someone was already on that dose of aspirin or they were on clopidogrel 75 milligrams alone and they had a stroke, then you would consider going to dual therapy as well. Now, remember with the situation, so say they were already on the aspirin or the clopidogrel and they had a stroke, you would hold whichever one they were on for the first 24 to 48 hours so TPA could be given, and then you would resume both of them together. So long-term antiplatelet therapy, so this is talking about beyond that 21 days or beyond that 90 days in the particular circumstances. You would use either aspirin, 81 or 325, or the clopidogrel. And the clopidogrel is known as Plavix on the brand name there. So you would use either one of those, and dual therapy is not recommended for long term. Whether or not you use an 81 milligram or 325 milligram aspirin is really just based on the patient, what their stroke looked like, what their TIA may look like. If it was more severe, you may go with possibly the higher dose, but if there's an increased risk of bleeding for some reason, then you may go with the lower dose. Okay, so some aspirin pearls. So in the previous doses that we just went over, none of the aspirin doses actually exceeded 325 milligrams per day. However, I do want you to be aware that aspirin is on the Beers criteria list, and it is recommended to avoid doses over 325 unless GI prophylaxis is given, and other alternatives not an option. So in older individuals, you may want to consider something to help protect the stomach to prevent GI bleeding. And then also maybe not use in someone who has not use a 325 and someone who has a high risk for falls and those types of things. And so in the geriatric population, please be cautious and don't overdo the aspirin. So clopidogrel, or brand name is Plavix. It is a first-line secondary preventative for ischemic stroke, and antiplatelet effects relies on a conversion that occurs to an active metabolite by the P450 system. I'm sure you guys loved the P450 system in school, and we're super excited to learn about it. Well, it comes back with lots and lots of medicines that they go through this P450 system. Specifically, the CYP2C19 is the marker here that you would be looking for. And there's a group of individuals that are poor metabolizers of this. And depending on the research, which article you read, the percentage changes a bit, but it seems to be about 10%. And that's probably a little bit of a high number, but about 10% of the population are poor metabolizers of the CYP2C19. And so in individuals who are poor metabolizers, they are not going to have the same effect from Plavix that someone else would. And so you would want to recognize that and maybe do a blood test to determine that if that's suspected. Anticoagulation therapy. So antiplatelet is what aspirin and clopidogrel fall under, but anticoagulation therapy is actually what is preferred and what's recommended for individuals where the cause of their stroke may be from atrial fibrillation, venous thromboembolism, or mechanical heart valve. And so we'll talk about those types of medications. We won't get in huge detail, but we'll do a brief run through of them. So these charts are absolutely wonderful. I'm so glad that I was able to find something that included everything. And I feel like these medications are changing so frequently. There's new ones all the time. So in this chart, I'm going to be toggling between this page and the next page because the chart continues. But you'll see here Coumadin, warfarin is the generic name. It's been used for years, pre-1982. It's approved for stroke and prevention in atrial fib and valve replacements. So strokes caused by atrial fib and treatment and prevention of DVTs and pulmonary embolism. The dosing is daily. There's a very slow onset with it, and doesn't really affect the kidneys. And food, we know that with warfarin, there's a vitamin K interaction. So you want to be cautious about how much vitamin K the patient is taking in. And whatever vitamin K they do take in needs to be consistent so that INRs aren't going up and down. There's lots of drug interactions with warfarin. There's some antibiotics that interfere, along with many other medications. And as you probably know, it requires monitoring through INR, and reversal agents are available though for warfarin, and that's going to be your vitamin K, your fresh frozen plasma, prothrombin complex concentrates. And we'll talk about those a little bit on the next few slides. And so next we're moving to the second column there, the Pradaxa, which is the dabigatran. And these are all, everything from here to the rest of the chart are fairly new medications. And this one came out October of 2010, and it's approved for strokes that have been non-valve or atrial fibrillation related, and for treatment and secondary prevention of DVTs and pulmonary embolisms, and then VTE prevention after hip surgery. So that's one that some of the newer medications have FDA approval for. And its dosing is there as well. It's given twice a day. The onset is a few hours, and it does have some kidney effects. So the kidney function does affect the dosage, I should say. And then there's no food interaction, which is good, nice to have that. There are few drug interactions similar to the other medications, and then no routine lab monitoring. And so I'm going to, I'm going to pause there just for a second. We'll say here too with the reversal agents, if you notice there is a reversal agent available, and we'll talk about that medication in just a minute, but it's the idarucizumab that is available for the reversal of the dabigatran. And so it's nice that there is something available for that. So the reason why I wanted to pause for a second is I want you to look at this chart moving to the right, and you will see that all of these medications, the rivaroxaban, the abaxaban, the indoxaban, betroxaban, all of these newer ones, they have similar onset. And they all, kidney function does affect the dosing, and so you have to pay attention to that. And then the food effect is different in the two columns there. The rivaroxaban and the betroxaban both have some food interaction. Like the Xarelto should not be taken with the dinner meal, and then the Vivexa should be taken at the same time of day with food, but there's not major food interactions like there is with the warfarin. So I wanted you guys to notice that. And then we'll go back to the first slide here. So also, because these have very similar approvals, I'm not going to read through every single one for you, but just kind of show you that basically all of these are approved except the betroxaban to be used in stroke. And that's why we're going to focus on those first 5 medications the most, because those are approved for strokes following atrial fib. So that's what I want you to take away from that. And then on this second page, that basically very little food interaction besides the 2 that we mentioned, and that all may need dosing based on kidney function. So that's what we kind of want to take away. And then if you'll look at the very bottom here with the reversal agents, the first 4 medicines that are covered do all have reversal agents, and we are going to discuss those in just a minute. Where the second 2, everything that's used, I'm sorry, not the second 2, the very last 2, everything that is used to reverse them is not FDA approved. It is pending approval. So hemorrhagic stroke management with anticoagulation. So if you have an individual that presents with a hemorrhagic stroke and they are on one of these medications, so say they had a previous ischemic stroke and it was due to AFib, and they were started on these medicines, say they were started on warfarin, and then they come back and they have a hemorrhagic stroke. So what are we going to do? So in that initial phase, whatever the anticoagulation medication is, it has to be stopped. You cannot continue it during the hemorrhagic event because it's going to get worse. So we have to stop the bleeding. So for those who are on warfarin, you're going to stop the warfarin and give vitamin K to help normalize the INR. And then for those that are on these other medications, the dabigatran, the rivaroxaban, the abaxaban, edoxaban, and the betrixaban. All of those you're going to follow the FDA guidelines for the drugs that are approved for each medication. And so the I'm sorry, I pronounced that wrong. Idarucizumab is approved for the reversal of the Pradaxa. So that's something you could use. And then andexanet alpha is approved for the rivaroxaban and the abaxaban. And so we'll talk about those here in a little bit as well. But these are the options. Now, some of these towards the bottom, it is kind of off-label, off FDA approval, but they're things that may be used, especially if these people are on these medications for another reason, especially Bivexa. Maybe they started it for DVT and now they have a hemorrhagic stroke and nothing yet has been approved. And so you may have to use some of these other agents that are in research, looking at, do they seem to help? And and from the slide prior, you can see that the PCC, so the prothrombin complex concentrate, can be used in emergencies in those in the Cyvasa and the Bivexa. Okay, so this is idarucizumab, and it is approved for reversal for the dabigatran only. That is the only drug that is approved for reversal. And the recommended dose is basically 5 grams given as 2 doses. So you split it in half and give 2.5 milligrams IV. And then if they do not have the desired outcome, you could give an additional 5 grams in patients that continue to bleed. Now, you want to be cautious with giving additional doses or extra medication because you're reversing what the condition is treating. So these people are on antiplatelet therapy for a reason. So if they have atrial fibrillation and you reverse their antiplatelet therapy, anticoagulation therapy, then they may have an event. And so we want to be cautious with that. So the other big caution thing on this medication is it contains sorbitol. So if someone has a hereditary fructose intolerance, they cannot have this medication. And then andexanet alpha, brand name is Andexa, and it is FDA approved to reverse life-threatening bleeding associated with the anti-XA agents. Those can be used, and then black box warning on this one for arterial and venous thromboembolic events. Of course, this is similar to the one we just went over because you're reversing the effects of the anticoagulation medication. You're more likely to have ischemic events, strokes, things like that. Also with this medication, cardiac arrest and sudden death has been observed. So very, very cautious if you are to give this medication. Okay, so the andexanet alpha, brand name Andexa again, dose is based on the medication that you're reversing, how much they are on, and when was the last time the person received the dose. It is given in an IV bolus, and then infused over the next 120 minutes. So the dosing is here on the slide if you need it. And then prothrombin complex concentrate, brand name is Concentra, blood coagulation replacement factor, basically. And it's to reverse the anti-clotting properties from vitamin K antagonists. So that would be the warfarin. And so it's approved to use in acute major bleeding, or if there is a need for a urgent surgery in someone who's on this medication. So the dosing is based on their pre-treatment INR and the weight of the patient. Now there is a black box warning, very similar to the other medications for arterial and venous thromboembolic complications, because you're reversing warfarin basically, and now they're clotting again. So here's the dosing on that. So the pre-treatment INR is there at the top, and then you're going to give them so many units based on their weight, but not to exceed the number in the bottom of the graph there. So that's the dosing on that one. So hemorrhagic stroke management, if the individual that you're treating for the hemorrhagic stroke is at a high risk for another ischemic event due to mechanical heart valve or a prior ischemic stroke, then you really want to consider restarting that anticoagulation therapy within about 2 weeks of the hemorrhage, if you can. But in other cases, if say it was for a previous DVT or something along those lines, you want to hold it for about 4 weeks to prevent a recurrent hemorrhage. Now, in that first case, if you restart their medication, be on the lookout and make sure that they are not having signs of a recurrent hemorrhage. Okay, so hemorrhagic stroke management with the blood pressure. In the acute phase, you're going to keep the blood pressure systolic around 150 to 220. Don't titrate down below the 140 because the kidneys need perfusion. And if you go too low, you may have kidney complications. In large controlled trials, they actually showed there was no advantage to aggressive blood pressure in regards to death or disability, but they did see that renal complications were more likely to occur in those whose blood pressure was treated down below 140. So managing the intracranial pressure, you want to, these patients are going to be in ICU type settings. You want to elevate the head of the bed by 30 degrees, maybe give mild sedation for comfort, IV fluids to keep volume up, and then consider steroids to help lower the intracranial pressure, and cerebral fluid drainage if needed, and then osmotic therapy with hypertonic fluids or mannitol. Seizure management, I do want to talk about this one. So seizures can occur in about 15% of patients with intracranial hemorrhage. These may not be non-convulsive seizures, so it is worthwhile maybe to get an EEG if you think they may be having seizures, but they don't look like your typical, grand mal type tonic-clonic seizure. You can get an EEG to see if that's if they are having seizures, if they're having some kind of partial seizures possibly. And then treat acute seizures with IV anti-seizure treatment to stop the seizures. And then you're going to transition to more long-term oral seizure preventative. Now, the 2015 guidelines do not recommend treating for seizures prophylactically, especially with drugs like Dilantin and the phenytoin. So you wouldn't use preventative, you would only use if the patient has the seizure. And then surgical management in the hemorrhagic patient, considering those with large hemorrhages and those who are deteriorating quickly. So prevention of cerebral vascular disease, this is the last part of our presentation today, and then we will move into some case studies. So long-term prevention of stroke in general, we're going to make sure we're maintaining good blood pressure, systolic less than 140 and diastolic less than 90. Consider an angiotensin converting enzyme or an angiotensin receptor blocker, as these may promote a reduction in stroke risk over other FDA-approved blood pressure medications. And so if you're going to be choosing medications, ACE or ARBs may be the better option. You want to do statin therapy. Long-term intensive statin therapy has shown evidence at preventing strokes and should be considered after a stroke or TIA. Smoking cessation, controlled diabetes, exercise, at least 30 minutes of moderate intensity exercise on most days, and maintaining a healthy weight. In summary, cerebral vascular disease is the most common cause of disability and death in older adults. Efforts in research over the past few decades have yielded treatments that may reduce the incidence significantly in high-risk populations. Rapid detection and treatment can greatly improve the outcomes. A history of stroke or TIA is a powerful stroke risk factor, and primary and secondary stroke prevention can greatly reduce the risk and preserve neurological function. So I hope you've learned a whole lot from this presentation. We are going to talk about some case studies and kind of test your knowledge here. So case study number 1. Susan is a 76-year-old female. She presents to the clinic with a headache, left-sided paralysis, and confusion. She has a history of falls. She lives in an assisted living facility, and she was brought in after an employee of the facility found her in her apartment confused. Which initial diagnostic tool would be most helpful for Susan? A, an MRI brain with and without contrast. B, a CT of the brain without contrast. C, an EEG to rule out seizures. Or D, a transcranial Doppler. So what would you do for Susan first? I'll give you some time to answer. Okay, so the answer here is a CT of the brain without contrast. So Susan has quite a few risk factors. She's older, and she also lives in assisted living. She has a history of falls. No one knows what exactly happened because she was found. And so she could have had an ischemic event. We don't know the onset, how long it's been, and we don't know if she has had a fall directly right before this, before she was found. And so we do want to do a CT of the brain first to make sure that she does not have a hemorrhagic event. And especially with her history of falls, because it might not be a hemorrhagic ischemic event, but she may have a subdural hematoma or something along those lines, or she could have had still an ischemic event. So we definitely want to go ahead and get a CT of the brain in her situation. Here we are with case number 2. So John, a 62-year-old male, presents to your office with complaints of an earlier episode this morning of right arm weakness. He was unable to lift his arm to feed himself. He laid down to rest, and this resolved after about an hour and hasn't reoccurred. He denies a history of this occurring before, but notes that about a month ago, he had an episode of slurred speech. This lasted about 30 minutes prior to resolving. He has a history of diabetes and hypertension. His current blood pressure is 152/92 millimeters of mercury. You do a neuro exam and there is no focal weakness. What is the most appropriate action to take? A, referral to a cardiologist for a cardiac workup. B, increase his blood pressure medication. C, referral to a local hospital with a stroke unit, or D, send the patient to an outpatient imaging facility for a CT brain without contrast? I'll give you time to work through the question and come up with your answer. Okay. So the answer is referral to a local hospital with a stroke unit. If you were able to look at his ABCD score, you would notice that he meets the criteria to go ahead and be sent to a hospital. Also, because he's had this occur before, he's at a higher risk for it turning into a stroke, and so he does need to be worked up. Okay, so John is admitted to the local hospital with a stroke unit. He's worked up for microvascular disease, and he was not found to have any detectable blockages or cardiac stenosis. And his EKG and 24-hour cardiac monitoring was negative for AFib. He was started on a statin before discharge. What are the next steps for John? A, titrate his blood pressure medication to a goal blood pressure of less than systolic blood pressure of 140 and diastolic 90. Consider a 30-day Holter monitor system to screen for intermittent AFib. C, adjust diabetes treatment and encourage diet and exercise to help reduce his A1C to a goal of less than 7. Or D, all of the above. I'll give you a few minutes. And the answer is all of the above. The criteria is to titrate the blood pressure to those parameters. And even though he did not have, the EKG did not show anything, it's a good idea to consider a longer Holter monitor. And then for the adjustment for his diabetes, that's always good to get the goal down, and that's one of the recommendations for stroke prevention. That is the end of our presentation. So I hope you enjoyed the presentation and that you learned a lot about ischemic and hemorrhagic strokes. And if there are any additional questions, I believe they are going to give my contact information so that you can send those to me. But have a nice day. Bye-bye.